Now, I'll be discussing key important points about how to write an exam in terms of marks distribution that you have when you approach a 3 marks question, when you approach a 5 marks question, when you approach a 10 marks question, right? So we'll try to understand that when an examiner is correcting a paper, what is the expected component in each individual of this, right? So we'll create, sir, I mean answers from Bailey. Beta, you will get answers from Bailey only, so don't worry about it. We will give you the top-notch information and that too in the best form as well. Okay, so don't worry about it. Now, there is a standard performer in which we would expect an answer. So when I talk about the performer in which I would ask a particular, whenever we're talking about any discussion or any topic, how to approach an answer. Now, the first thing in the performer that I would expect is going to be a definition. It is going to define a particular component or start with simple definition. So first is the definition. Second, once you have defined it, if there is a pathophysiology, a quick line on the pathophysiology of the disease. If you have no pathophysiology, then you will move on to the third point, that is going to be the clinical features. Once you have done the clinical features, based upon the clinical features, if there are any differential diagnosis, you will mention a differential diagnosis. Then it is about investigation. And if there are any findings on investigation, then you can. After investigation, it is going to be management. Now, if the management is surgical, always mention about the post-operative complications. The expected post-operative complications and the management of it, right? So whenever you will write any answer, right? Any answer, this is the performer that you're going to follow, but this performer is going to hold for a 10 marks question. So when you are approaching a 10 marks question, you will define whatever, let's say you're talking about wound or an ulcer, you will say what is an ulcer? It is breach in the continuity of the epithelium or the mucosal membrane due to microscopic death of tissue as well as tissue necrosis. That is what an ulcer is defined as. So first is definition. Then the pathophysiology. In the pathophysiology, if the pathophysiology is not there, then you can talk about the causes of that particular disease. If these causes are not there, you can talk about a risk factor. Now, for example, if there's a question on breast cancer, they would want you to tell the risk factors of breast cancer. In the risk factors of breast cancer, you should know what are the modifiable risk factors, what are non-modifiable risk factors. Just quickly write 4 points or the 4 risk factors that are present. Once you're done with the risk factors, how the patient presents to you and what are the differential diagnoses based upon, see, whatever the clinical features that you have written, and the same, like for example, patient presents to you with a huge lump rapidly growing in size and then it is infiltrating the skin as well, there's an ulceration. So you have 2 components, either it could be a phylloids or it could be a breast cancer, right? Now phylloids, again, age of presentation, if it is under 40, more likely to be phylloids, more than 40, more likely to be malignancy. That is how you're going to describe it. Then we'll go into the investigation. After the investigation, we'll talk about the management. In the management, always mention if it is the first, for example, we're talking about inflammatory bowel disease. In an IBD or an inflammatory bowel disease, the first line of management is always a medical management. Refractory IBDs. For Crohn's disease, if the patient presents with obstruction, you go with intervention. In ulcerative colitis, if it is a fulminant or ulcerative colitis, then you will go ahead and then move on to surgical. That is a total proctal colectomy with ileoanal anastomosis with J pouch, right? All these are going to be there in the management and the post-operative complication. Now, in a 10 marks question, where would we expect a diagram? Usually, whenever we talk about the management, this is where the diagram is going to be helpful. If you're talking about the pathophysiology, in the pathophysiology, I would expect a diagram, right? Nowhere else that I will be keen on diagrams, so you need to be precise wherever possible. Whenever you are talking about differential diagnosis, if possible, give a table. Now, table is going to be comparison between the 2 differentials or 3 differentials that are talking about and how do you differentiate that in a quick succession. If you follow this performer, no, if it is a 3 marks question, the 3 marks question usually holds 1 or 2 points, right? Now, if they say about fibroadenoma, you define pathophysiology, clinical features, and management. So if the first 3 is to be there, it is for 3 marks. For a 5 marks, I will go ahead with each individual point, but only write until the management, that is a 5 marks. and the entire set has to be followed. This is going to be a 10 marks question. Simple, right? So you now know that what to write for 3 marks, what to write for 5 marks, what is to write for 10 marks question. If you follow this performer in your exam, every single examiner is going to just love the representation and they'll go through it. You need to understand the examiner's mindset also, because they have to correct a lot of question papers. See, the key is going to be handwriting. You have to make sure if your handwriting is not good, but write neatly. Underline whatever is the important points. Highlight, you just need to underline. For example, you're writing a topic, clinical features, underline it. Then put points, points, points. Because when you write in points, they know that you're not cooking up story. When you start writing in paragraphs, that is when they know it is going to be a story representation, right? So this is the key components that I wanted to tell you about how to write an answer, especially in a surgery paper. So let's dig into your previous exam questions and then we'll try to discuss each one of them. So today I'll be discussing the various questions. The first question is going to be about the wounds. So I'm just going to summarize all the questions that we found on wounds and I'll tell you how to write about it, right? Now, the question was define different kinds of wounds or ulcer, right? Then they're asked about the wound healing, that is the phases of wound healing. Phases of wound healing was an exam question. Phases of wound healing. There's a question that is factors affecting wound healing, or I said delaying wound healing. Factors delaying wound healing. So you have phases of wound healing, factors that delays the wound healing, ulcer and management, ulcer and its management. They've asked you specifically about the pressure ulcer. They've asked you specifically about the pressure ulcer. Classification of surgical wounds. Classification of surgical wounds. And the last question on wounds that they asked you is surgical site infection. SSI stands for surgical site infection. So whenever a question is being asked, that we have gone through all the university questions that are present. So these are the usual questions that they ask you from the wound, right? Now, if you look at each individual one, no, your phase of wound healing is a 3-mark question. Factors delaying wound healing is a 3 marks question. Ulcer management is 3 marks. Pressure ulcer its management is 5 marks. Classification of surgical wound is going to be 5 marks. Surgical site infection is going to be 5 marks. And if they add 2-3 components, it will become 10 marks, right? So this is the marks distribution that you have for each individual topic per se. So let's say you're attempting this question, how would you like to write about it? So we'll talk about the phases of wound healing. How are you going to present it? I'm going to keep it very crisp so that you understand and how to write about your answer. So the answer to this question, the first one is going to be the phases of wound healing. So before we start the phases of wound healing, in the phases of wound healing, if the question is determined in this particular form, right? In the phases of wound healing, the first thing you will determine that it is going to be an acute or chronic wound. So we're talking about all the phases that we're talking about. It is about the acute phases of the wound healing. So we'll divide. So when you're writing the answer, divide them into 3 components. The phases of wound healing, that is the acute wound healing, can be divided into 3 subphases. They can be divided into 3 sub-phases and mention all these 3 sub-phases. What are the 3 sub-phases of the wound healing? I hope everybody knows it. You have an early phase. You have an intermediate phase. You have an early phase, the intermediate phase, and the late phase of wound healing, right? Now they'll ask you what are the components that present to you as an early phase of the wound healing. In an early phase, the first phase of the wound healing is going to be hemostasis. And the second phase is going to be inflammation. The second phase is going to be inflammation. Now in the intermediate phase, you will have fibroblast migration. You have the fibroblast migration. Then you have angiogenesis. Fibroblast migration, angiogenesis, and epithelialization. And the epithelialization. Right? These are your intermediate. What are the late phases? The late phase would be your collagen synthesis. Your collagen synthesis. Your wound contraction. And the last phase of the wound healing is going to be scar formation and remodeling. It is the scar formation and remodeling. It is the scar formation and remodeling. Right? Where types of ulcer we're going to discuss. No, where the ulcer and its management, will talk about all the different types of ulcers. We'll cover everything. Okay? Now, whenever they ask you about the phase of wound healing, first write this. The minute you write this, the examiner knows that you know there are 3 different phases of wound healing. That is going to be an early, intermediate, and late phase. Right? Now, they also want to know whether you know that what are the timelines of the wound healing. Now, the timelines of the wound healing. So the next side heading that you will see is the timeline of wound healing. Now in the timeline of the wound healing, you should know that which of the following starts at what point and ends at what point. That means hemostasis starts when, inflammation is going to start when, stop when, all that are important, right? So in the timeline of the wound healing, I'm just going to take the entire subset of the wound healing into one linear progression, right? So let's say this is the timeline of the wound healing. Just draw a single line. The start point is what we call it as the day the wound was created. So this is going to be your day 0. This is going to be day 0, the day patient had a wound being created or the wound was formed. And the last one is going to be at the end of the 6th week. So the acute phase of the wound healing starts from day 0 to 6th week, right? Now what you're going to do is you're going to divide this entire wound component into day 1. That is the day 1. This is day 2. This is day 3. This is day 4. This is day 5. This is day 6. And let's say this is day 7. After that, this will be your 2nd week. This is going to be your 3rd week. This is going to be your 4th week. This is your 5th week. And at the end, you have the 6th week, right? So these are the phases of the wound healing starting from day 0 all the way to day 6. Now, in the timelines of wound healing, you will write everything that is going to start above this. So this is the start point. And this is going to be the end point, right? Now, on day 0, what is going to start? Remember, on day 0, there are 2 events that are going to start. Number 1, there will be hemostasis. And number 2, there is a phase of inflammation. The hemostasis and the phase of inflammation starts on day 0. What ends on day 0? Again, it is the hemostasis. It is the hemostasis that ends on day 0 as well. So what starts on day 0? It is the hemostasis inflammation. What ends? It is going to be hemostasis. When does the inflammation end? Remember, the inflammation is going to end on day 4. So inflammation starts on day 0, but it is going to end on day 4, right? The first day is going to be a holiday. There is nothing which is going to happen on day 1. On day 2, you will notice there will be fibroblast migration would start. So on day 2, what is the event that you are looking at? It is the fibroblast migration. Now the fibroblast migration starts on day 2, but the fibroblast migration, it is going to end on day 4. Starts on day 2, ends on day 4, right? So what is going to happen on day 3? Remember, day 3 is the day when the collagen synthesis would start. Now, very important thing is the collagen synthesis starts on day 3, but the synthesis is going to be very, very little until the 2nd week. Now, once it hits the 2nd week, from the 2nd week, it is going to shoot up. So there is a sudden increase in collagen synthesis called as the acceleration phase. And then it peaks onto the 4th week, and then it starts declining. And by the end of the 6th week, it plateaus off, right? So in the collagen synthesis, you need to tell that the peak of the collagen synthesis The peak of the collagen synthesis is going to be at the 4th week. From the 2nd week, it is going to be accelerating phase. This is going to be the accelerating phase. And after the 4th week, it decelerates. And by the 6th week, it plateaus off. That is in terms of collagen synthesis. On day 4, what is going to start? In day 4, you will see the wound contraction. It is the wound contraction that starts on day 4. And this is going to end anywhere between 2nd to 3rd week. Usually by the 3rd week. So the wound contraction ends. Now, one thing that you need to know that is scar remodeling will take 15 to 18 months or almost approximately 2 years. So the one point that you can add at the end in the entire discussion, that you can say the scar remodeling is going to last for approximately 2 years. So it continues to go ahead with remodeling for 2 years, right? Now, if they ask you the phases of wound healing, in the phase of wound healing, if they have asked you for a 3 marks question, this is what is expected from you, right? If you write this much, you will never, like, no examiner is going to take anything out of your pocket. In fact, they will give you 3. 3 out of 3 is bound to be there in your exam paper, right? So that the early phases, the intermediate phase, and the late phase of the wound healing, right? Now, once you have written this, next comes is going to be, so we have first part, phases of wound healing, we have already determined. Next is going to be about your factors that delay the wound healing, right? So factors delaying wound healing. Factors delaying wound healing. So factors that delay wound healing is your second question, right? So when I talk about factors that delay the wound healing, I'm going to write them into 3 contexts. That is going to be your intrinsic and the extrinsic factors. So you immediately make them into 2 separate tables. We say the intrinsic and the extrinsic factors. The intrinsic and the extrinsic factors. So what do you mean by this intrinsic and extrinsic factor? Just for the easy way to remember it, when we say an intrinsic factor, the factors are localized to the wound site. Extrinsic factors, they're not localized to wound site, but they're present in the body at a systemic cause, right? Now when you look at the intrinsic factors, what are the examples of the intrinsic factor? Presence of foreign body in the wound. Presence of foreign body inside the wound. Presence of a necrotic tissue within the wound site. Recurrent trauma to the wound site. Recurrent trauma to the wound site. If the wound is associated with hypoxia or ischemia. If the wound is associated with hypoxia as well as ischemia, if it is secondary to venous insufficiency. The best example of a wound that is created by a venous insufficiency is going to be a varicose vein. Along with that, presence of an active infection. Presence of an active infection, and if a wound is due to a radiation exposure, or it's a wound that is created due to radiation status. Extrinsic factors, which are going to be systemic factors, not the local factors. So rather than saying intrinsic, you can also use local factors. We can name them as the local factors. Extrinsic factor is what we call it as systemic factors. We can call this as systemic factors. Now look at the extrinsic or the systemic factors. Best example is going to be your diabetic patient. It's a diabetic mellitus. The diabetic patients. Diabetic mellitus. Then you have smokers. Smoking causes poor collagen synthesis, and poor collagen will result in poor wound healing. So there's diabetes, there is smoking, usage of steroids, patient who already have a collagen vascular disease, patient with a collagen vascular disease, if it is secondary to a malignancy, patient who is going to have jaundice. So jaundice, which is usually associated with chronic liver disease, example like cirrhosis. Along with jaundice, if it is going to be uremia, uremia is associated with chronic kidney disease. Uremia is associated with that of the chronic kidney disease, right? So these are the factors that are going to cause delayed wound healing. Now you have divided them into two components, the intrinsic and the extrinsic factors, and this is your 3 marks question, right? So if they ask you for 3 marks, these are the various factors that you have to write. And obviously, whenever you're writing an answer, always start with the definition and then go ahead with these ones. So that just gives you more add-on points, right? Now, so these are the factors that delay the wound healing, right? So we have completed the first one, that is going to be the phases of wound healing, factors that delay the wound healing, right? The third question is going to be your ulcer and its management, right? So we'll talk about the types of ulcer and the ulcers management. So we'll talk about the various types of ulcer. So when it comes down to ulcer, now the basic classification of an ulcer, first is the definition itself. So define ulcer. Ulcer is a breach in continuity of epithelium, an epithelium or a mucous membrane, due to microscopic death of tissue associated with necrosis. It is associated with necrosis is what we call it as ulcer, right? That's the first point you write. Then when you're going to classify ulcer, so the second point will be your ulcer classification. Now, whenever we classify ulcer, the ulcers are classified predominantly into 3 varieties. They are going to be healing ulcers, spreading ulcers, and callus. So we divide them into 3 subcategories. We have the healing ulcer, we have the spreading ulcer, and then you have callus. Now, what is a callus? Callus ulcer is basically chronic non-healing ulcer. It is a chronic non-healing ulcer. Now, please do not make a mistake as writing non-healing ulcer as a type. It does not exist, right? Either the ulcer is healing or it is spreading or callus. Callus is a variety of a non-healing ulcer where you have because of chronic inflammation, right? So chronic non-healing ulcer is what we call it as the callus ulcers. The minute you say these, then they would expect the parts of the ulcer. So the next point that you will immediately write is going to be the parts of ulcer. Now, if this is where you have to come up with a diagram. So in a parts of the ulcer, this is the normal skin surface. This is going to be the ulcer. This is where it is going to rest upon, right? So let's say if this is the wound bed that you're talking about, and this is where it is going to rest upon, right? The ulcer is sitting on top of here, and this is the skin surface, and let's say this is the ulcer that is breached. Remember, you need to learn how to draw stick diagrams, which is going to be very important and handy in the exam as well. Because if you draw neatly and if you draw well, all your explanation is going to be covered there and then itself, right? Now, what are the parts of the ulcer? Now, when you look at this, this is the normal skin. This is the normal skin that you have, and this portion that you're seeing is in the ulcer. Now the junction between the normal skin and the ulcer, it is what we call it as the margin. So when you write like this, always mention margin is the junction. It is the junction between the normal skin and ulcer. Then you see this area which is touching, the area that is resting on the lower part, which you see here, this is what we call it as the floor of the ulcer, right? Now on which what is resting, this is what we call it as the base of the ulcer. Now floor is the most dependent part of the ulcer. This is the most dependent part of the ulcer. The base of the ulcer is basically on which it is going to rest on. So it is the resting surface of the ulcer. It is the resting surface of the ulcer. Next you can see this area. So the area that is going to be present, between the edge, right, between the margin and the floor, this is what we call it as the edge of the ulcer. This is what we call it as the edge of the ulcer. So between the margin and the floor, you will see, right, it is going to be between the margin and the floor, you will see the edge of the ulcer, right? So edge of the ulcer is that part of the ulcer, it is between the margin and the floor of the ulcer. And the floor of the ulcer. Now if you want to impress your examiners, you can add another point in the edge. Metabolically the most active site of the ulcer. As a note point you can write here, you can say metabolically most active site. Metabolically the most active site of the ulcer is the edge. That is why whenever you're suspecting any malignant ulcer, you'll always take an edge biopsy. You'll always say an edge biopsy, right? So these are the various parts of the ulcer and their significance. I have given it to you. The same diagram you have to replicate in your exam. It's a sticks line diagram. Anybody can draw it. Just make sure you practice once and you know exact positions, right? So you should mark it down where exactly you have the margin, where exactly is the floor, and where exactly you can see the edge of the ulcer. Remember, edge is the metabolically most active site. Edge happens to be metabolically the most active site of the ulcer. It is metabolically the most active site of the ulcer. Okay? Now, once you've done the parts of the ulcer, then you talk about, based upon the edge, you can classify ulcers, right? So talk about the various ulcers based upon the edge. So ulcer based upon the edge that you can classify. Now look at the edges. There are different kinds of edges that you have. The first one that you will see is what we call it as a sloping edge. So you just draw a small line diagram, make the ulcer slope in, and like this. This is what we call it as a sloping edge. It is called as a sloping edge because imagine that if you're sitting at the edge of the ulcer, you will just simply slide into the ulcer. So hence it is called as a sloping edge. Right? Now, the first type is going to be the sloping edge ulcer. This is going to be a sloping edge of the ulcer. This is going to be a sloping edge of the ulcer. So where do you see the sloping edge? The first condition that you will see, it is going to be present in all healing ulcers. The second one that you will see, it is going to be on the venous ulcers. It is going to be the venous ulcers. Now, as we all know, venous ulcers are seen in varicose veins. Okay? So when you talk about it, there we'll talk about the characteristics of venous ulcer also. But for now, you remember the sloping edge is seen in your healing ulcers and the venous ulcer. The second one that you will see is going to be an edge which is going to dig in, and that is going to be your undermined edge. This is what we call it as an undermined edge. Why it is called as an undermined edge? If you are here, if you are standing here, you can go under the ulcer. You can travel deep into the ulcer. So it is called as an undermined edge, right? This is what we call it as an undermined edge. This is what we call it as an undermined edge. Undermined edges are seen in your tubercular ulcer. That is because of TB. It is seen in the tubercular ulcer and the necrotizing fasciitis. And the necrotizing fasciitis. And the necrotizing fasciitis, right? This is about your undermined edge. Now the third edge that you will see, it is going to be a punched out edge. So you will see this is the surface of the skin. You will see this is the ulcer depth, but you will see the ulcer is going to elevate above the surface of the skin. So if you see this is the ulcer's border, you will see the ulcer will be like this, right? So if the ulcer's edge elevates above the margin, this is what we call it as the punched out edge. So this is what we call it as the punched. This is what we call it as the punched out edge. Now, where do you see a punched out edge? It is seen in your syphilitic ulcer. It is seen in the syphilitic ulcer and also in your diabetic foot, that is your trophic ulcer. So it is the punched out edge, or also called as the syphilitic ulcer or is in trophic ulcer. Another variety of the ulcer edge that you will see, it is going to be raised and everted. So again, you take this as the representation of the skin. This happens to be the ulcer. And when you see the ulcer's edge, so this is the ulcer that is present. You see it is going to go up and it is going to present like this. So the edge is growing over the normal skin. So if the edge protrudes and then grows over the normal skin and you can dig between these two areas, this is what we call it as raised and everted. It is going to be your raised and everted edge. This is your raised and everted. So in a raised and everted edge is a characteristic feature of squamous cell carcinoma of the skin. This is seen in the squamous cell cancer of the skin, or it is also seen in Marjolin's ulcer. See, remember, Marjolin's ulcer is nothing but a squamous cell cancer, but Marjolin's, if you want to be more precise, this is what we call it as a low grade squamous cell cancer of the skin, usually seen post burns. This is usually seen post burns. So this is what we call as post burn ulcer, right? It is going to be seen in post burn ulcers. See, it is not somebody saying undermined edges are seen in all granulomatous diseases. Okay, wherever you have active proliferation of a disease, there you can have an undermined one, right? Example like necrotizing fasciitis, tubercular ulcers. If you talk about, there are certain ulcers which are secondary to an ischemic status, right? But not the diabetic foot ones. That is because of microangiopathy, right? There's a difference. Chalo. So the last one that you have, the last one is going to be your raised and beaded. So again, you determine this is the ulcer. This time you see this is the ulcer's edge, base and all. And then you see the ulcer at the tip looks like this. So it's not going over the skin, but you see that bluntness and raising above it. The bluntness of the ulcer and raises above the skin surface. So this is what we call it as. This is what we call it as raised and beaded. Now these beads are because of keratin pearls. They look like shiny keratin pearls. Right? Now this raised and beaded is seen in the basal cell carcinoma. It is seen in the basal cell carcinoma of the skin. It is in basal cell carcinoma of the skin. Right? So when we talk about the skin malignancies, we'll quickly discuss those as a smaller topics as well. But this is what is going to be asked in an exam. You are expected to draw all these in a quick succession, give at least 2 examples of each. And the last one you have to give one example so that you precisely are able to answer the question as it is asked, right? So these are about the various edges of the ulcer and its presentation, right? Now, once you talk about ulcer, once you're done with the ulcer, you always talk about the management of the ulcer. Now, ulcer management. Now, in the ulcers management, it is a stepwise approach. What is the first thing? Whenever a patient comes down to ulcer, you have to make sure the ulcer's base and the floor and the edge is clean, right? So the first one is going to be cleaning and debridement. It is a cleaning and debridement of the ulcer. There will be cleaning and debridement of ulcer. Second thing, you have to start the patient on antibiotic coverage. Start the patient on antibiotics. After that, if there is any factors, right? So, okay, whenever you talk about cleaning and debridement, it will take care of local factors. Then always address the comorbidities. So manage comorbidity. Now when you talk about management of the comorbidity, you have to manage diabetes. You have to manage if the patient is having CKD, if the patient is having jaundice, all that has to be managed, otherwise these wounds will not heal, right? So cleaning and debridement, antibiotic coverage, and manage comorbidities are the important steps in the ulcer management, right? Along with that, if there is ulcers because some specific cause, the fourth one is going to be to treat the underlying cause. To treat the underlying cause. To treat the underlying cause, right? So this is how you are going to go with ulcers management, right? So we finished 4 questions which are being asked in our exam, right? So we spoke about the phases of wound healing, factors delaying the wound healing, ulcer management. Now we'll discuss about the pressure ulcers, right? Again, pressure ulcer is usually a 5 marks question, so they will expect you to give a little bit of details. Here and there you should have to speak about it, and then we'll talk about the components as well. So the next topic that we'll talk about in this is going to be pressure ulcer. Now the question can come to you as a pressure ulcer. They can give you another synonym, that is your decubitus ulcer. This is also called as a decubitus ulcer. This is also called as bed sore. It is also called as the pressure sore. So all these are the synonyms that you remember. So it is a pressure ulcer, or you can say decubitus ulcer, a bed sore, or a pressure sore. Now, what are the different things that are determined here? The first one is the definition of a pressure ulcer. It is an ulcer formed. It is an ulcer formed due to persistent pressure. Due to a persistent pressure over an area exceeding capillary occlusive pressure, exceeding capillary occlusive pressure for significant time. For a significant time is what we call it as the pathophysiology, right? So this is the pathophysiology, just mention it as P. It is the definition as well as the pathophysiology of a pressure ulcer. It is the ulcer formed due to a persistent pressure over an area exceeding the capillary occlusive pressure for a significant period of time. Now, what is this capillary occlusive pressure? Remember, the capillary occlusive pressure is at 30 millimeters of mercury pressure. Now, if a pressure is more than 30 millimeters and it is for a longer duration of time, it will cause hypoxia and ischemia. It is going to be hypoxia as well as ischemia. Somebody is saying कि voice गूंज रही है. Beta, I don't. Anybody else having any issue with the audio? किसी और को लग रहा है कि आवाज गूंज रही है? ऐसा लग रहा है कि बज रहा है क्या? कान बज रहे हैं? नहीं ना? ठीक है. हाँ, तो जब हम प्रेशर अल्सर्स और डिक्यूबिटस अल्सर्स की बात कर रहे हैं, बेटा क्लासिफिकेशन ऑफ वुंड्स इज गोइंग टू बी द नेक्स्ट क्वेश्चन. और सब लिखा हुआ बेटा, देखो क्लासिफिकेशन ऑफ सर्जिकल वुंड्स आर देयर, सर्जिकल साइट इंफेक्शन इज देयर, अल्सर इज देयर, सब बात करेंगे, कोई टेंशन नहीं है. ठीक है, चलो. हाँ, तो वी आर टॉकिंग अबाउट द प्रेशर अल्सर, डिक्यूबिटस अल्सर्स, बेड सोर्स और प्रेशर सोर्स. प्रेशर अल्सर का जो पैथोफिजियोलॉजी है, दैट इज व्हेनेवर द प्रेशर एक्सर्टेड ओवर अ पर्टिकुलर साइट ऑफ अ बॉडी इज मोर देन दैट ऑफ अ कैपिलरी ओक्लूसिव प्रेशर, इज व्हाट वी कॉल इट एज द पैथोफिजियोलॉजी ऑफ योर बेड सोर और प्रेशर सोर. इसका मतलब क्या है? नाउ व्हेन यू एक्सर्ट प्रेशर, लेट्स से यू कैन सी माय palm here, when I exert pressure and when I release it, see I'm exerting pressure and I release it, that area is becoming white and slowly it becomes pink again. Now when I exert pressure, what am I doing? I am occluding the capillaries to this particular site. जब मैं capillaries को दबा रहा हूं तो blood flow to this area is reducing. ठीक है, नॉर्मली मैंने तो 2 सेकंड के लिए दबाया फिर निकाल दिया. इमेजिन करो कि यही प्रेशर कुछ घंटों तक बना रहा. ठीक है, 6 घंटे 8 घंटे. अब 6 से 8 घंटे तक अगर ऐसे ही प्रेशर रहेगा तो कैपिलरीज टू दिस एरियाज विल नॉट बी एबल टू प्रोवाइड ब्लड टू दैट पर्टिकुलर साइट. अगर ब्लड यहां पहुंचेगा ही नहीं तो हाइपोक्सिया हो जाएगा. हाइपोक्सिया की वजह से इश्कीमिया, इश्कीमिया विल कॉज टिश्यू नेक्रोसिस, टिश्यू नेक्रोसिस विल रिजल्ट इन अल्सरेशन. सो प्रेशर अल्सर की जो पैथोफिजियोलॉजी है, इसका पैथोफिजियोलॉजी का एक चार्ट बनाना पड़ेगा आपको, दैट इज ओक्लूजन ऑफ कैपिलरी प्रेशर ऑफ कैपिलरीज. It is the occlusion of capillaries resulting in poor perfusion over an area. Poor perfusion over an area where the pressure is exerted on the pressure site. Now, because of this poor perfusion over an area or a pressure site will result in hypoxia. This hypoxia will result in ischemia to that particular site, and this ischemia will result in tissue necrosis, and this tissue necrosis will result in ulceration. This tissue necrosis is going to result in ulceration. ठीक है, if you put this chart on, ये चार्ट अगर आप बना दोगे तो आपका एग्जामिनर ना पागल हो जाएगा, बोलेगा यार ये बंदा पढ़ के आया. ठीक है, सो द मिनट यू पुट दिस चार्ट, ही मतलब बाकी का आंसर वो पढ़ेगा ही नहीं. उसके बाद आप जो मर्जी लिख दो, अगर इतना लिख दिया ना तो बोलेगा कि भाई मतलब दिस गाई इज अ टॉपर. ठीक है, बस इस छोटा सा फ्लो चार्ट जहां पे आपने बता दिया कि जहां से देखो कैपिलरी प्रेशर पे ऑक्लूड हो गया, आपने लिख दिया कि कैपिलरी ओक्लूसिव प्रेशर 30 है, तो वो और पागल हो गया कि कैपिलरी ओक्लूसिव प्रेशर को पता है द मिनिमम प्रेशर रिक्वायर्ड टू ओक्लूड द कैपिलरीज इज गोइंग टू बी मोर देन और इक्वल टू 30. सो 30 मिलीमीटर ऑफ मर्करी इज गोइंग टू बी योर कैपिलरी ओक्लूसिव प्रेशर. अब कैपिलरी ओक्लूजन की वजह से परफ्यूजन कम हो गया, परफ्यूजन की वजह से हाइपोक्सिया हो गया, हाइपोक्सिया की वजह से इश्कीमिया, इश्कीमिया से टिश्यू नेक्रोसिस और नेक्रोसिस से अल्सरेशन. तो आपने तो इसको बता ही दिया कि प्रेशर अल्सर बनता कैसे. अच्छा, फिर ये पूछ लेगा व्हाट आर द साइट्स फॉर द प्रेशर अल्सर, व्हाट आर द प्रोन साइट्स. सो द सेकंड थिंग दैट यू हैव टू डू इज द साइट्स फॉर प्रेशर अल्सर. अगेन प्रेशर अल्सर के साइट्स ना आप या तो मेमोराइज कर लो या तो सिंपली समझ के याद रख लो. ठीक है, सो आई प्रेफर द सेकंड मेथड. अब आप मान लो कि ये बेड है जहां पे हमारा पेशेंट लेटा हुआ है, ही इज अ बेड रिडन पेशेंट, सो ही इज गोइंग टू हैव दिस. ठीक है, so in a bedridden patient, this is how the patient is going to lie down. ये इसका occiput है, ये इसकी body है. You will see these are the sites which will be present like this. ठीक है, अगर patient लेटा हुआ है, whichever site is in contact with the bed, यहां पे पूरी बॉडी का भार गिरेगा, और जैसे भार गिरेगा तो यहां पे प्रेशर ज्यादा होगा. जहां पे प्रेशर ज्यादा होगा वहां पे आपकी कैपिलरीज ओक्लूड हो जाएंगे, और जहां पे कैपिलरीज ओक्लूड हो जाएंगी वहां पे लो प्रेशर सिस्टम आ जाएगा. अगर लो प्रेशर हो जाएगा तो अभी तो बताया था हाइपोक्सिया, इश्कीमिया, अल्सरेशन, तो यही साइट्स है. तो साइट्स फॉर द प्रेशर अल्सर में अगर आपसे एग्जाम में पूछता है, आप देखो एक ये आपका सर है जो आपके पिलो, अगर पिलो है तो पिलो के बिना तो इट इज गोइंग टू एक्सर्ट मोर प्रेशर, इट इज गोइंग टू बी द ऑक्सीपुट। फिर आप देखोगे यूजुअली ना स्कैपुलर एरिया पे थोड़ा स्पेस आउट होता है तो उतना प्रेशर नहीं गिरता, लेकिन व्हेन यू कम डाउन टू हियर, यहां पे आपको 3 जगह मिलेंगी। इट इज गोइंग टू बी द इश्कियम, it is going to be the greater trochanter, ischium, greater trochanter, और इसी रीजन में एक और मिल जाएगा आपको sacrum. So there are the 3 sites where you will see the ulcers or the pressure more. Ischium is the overall most common site. ये आपका नीट पीजी का सवाल या फिर your competitive exam का क्वेश्चन भी है. Along with that, you have the sacrum as well as the greater trochanter. It is going to be your greater trochanter as well, right? उसके बाद अगर आप देखोगे ये heel है. So heel is going to be in a constant touch. So heel is the another site for the pressure ulcer. Now when the patient is bedridden, तो क्या होगा, जब लेटेगा तो उसके पैर laterally fold होंगे. जब वो laterally गिरेंगे तो कौन सा area is under the surface touch? It is the lateral malleus. ठीक है, तो एक और यहाँ पे याद रख लेना, it is the lateral malleus which is more commonly affected when compared to medial malleus. It is going to be the lateral malleus which is more commonly involved when compared to the medial malleus. ठीक है, so I'm just going to add here, lateral malleus is more commonly affected. Lateral malleus is more commonly affected when compared to medial malleus or the malleolus. ठीक है, so this is far more common. That is lateral malleus is far more common when compared to medial malleus. ठीक है, so these are the various sites where a patient would develop pressure ulcer. Then they'll ask you what are the risk factors for development of these pressure ulcers. The risk factors are quite simple. It is understandable also कि any patient who is going to be bedridden, any patient who is going to be bedridden, any patient who is a wheelchair bound status, it is going to be a wheelchair bound status, or if the patient is having prolonged immobilization. It is a prolonged immobilization. Now this prolonged immobilization is usually seen in this obese patients. I still remember I saw a case, that kid was I think around 17, 18 years old, and that kid was not very obese, but yeah, he was quite hefty, and he had a habit of playing video games, right? So he was into that, online gaming and all, and the history that he guys, he was in his hostel room. He did not get up from his position for 3 days. He was eating, sleeping in the same place and he's playing at the same time. He hardly got up for his business also, right? So वो पूरा दिन बैठा रहा, ठीक है, 3 दिन तक कंटिन्यूसली बैठा. 3 दिन के बाद obviously this that area started to discolor and he came down to us. I mean, luckily it was grade 2 only, so उसमें ज़्यादा problem नहीं हुआ. Otherwise it would have become much more difficult. So these are the important risk factors associated with that of the pressure ulcer. ठीक है. Now when we talk about what are the stages or the different grades of the pressure ulcer. So there are stages of pressure ulcer. जब भी आप ऐसा कुछ स्टेज लिखोगे ना, उसके लिए एक टेबल बनाना, stages of pressure ulcer. So when you're going to address this, when you're going to address the stages of the pressure ulcer, what we are going to do is we are going to write on one side the stage, on the other side you will write description, and then at the end management. So now the examiner knows कि आपको पता है कि pressure ulcer grade या stage wise manage होते हैं, ठीक है. So you have stage 1 pressure ulcer. Stage 1 में description है, there will be presence of non-blanching. There is non-blanching erythema. Now this non-blanching erythema, this redness, you try to exert pressure, that does not change or blanch away. That is because of subcutaneous ecchymosis. Here it is going to be conservative management. It is going to be a conservative management. Then you have grade 2 pressure ulcer, where you have partial thickness skin loss. Where you have a partial thickness skin loss. So when there is a partial thickness skin loss, again the management here is going to be conservative management. So grade 2 mein you will see there is only skin excoriation. Then you have grade 3. In grade 3 you have full thickness skin loss. So your examiner would also want to know that how do you know it's a partial or a full thickness skin loss. In a full thickness skin loss, subcutaneous fat is exposed. If you are able to see a subcutaneous fat being exposed, it is grade 3 or stage 3. Otherwise, it is going to be stage 2. So here you will require an active management. So we'll talk about it. What is an active management? Then you have stage 4. Stage 4, there is involvement. There is an involvement of underlying structures. There's an involvement of an underlying structure. Now, when you talk about the underlying structure, what underlying structure are we talking about? It could be a muscle, a vessel, a tendon, a nerve, anything, right? So when you talk about underlying structures, we're talking about whether it could be a muscle, it could be a vessel, it could be a tendon, or it could be a nerve. Or in fact, it can be a bone as well, anything. If there is any underlying structure is being involved, it will directly become stage 4. For stage 4 also, we would go with active management. So here also we'll go with active management. Latest addition to the pressure source that you have is what we call it as unstageable. Now what is this unstageable? If an ulcer is covered, if the ulcer is covered with necrosis or slough, presence of necrosis or slough over an ulcer will directly make it as unstageable. Reason क्या है? अगर necrosis और slough present है तो ulcer का depth कैसे पता चलेगा? ऐसे थोड़ा पता चलेगा कि वो अभी भी superficial है, कि इसने dermis breach किया है, subcutaneous fat exposed है, या फिर underlying bone या vessel involved है. कैसे पता चलेगा? अगर पूरा slough से भरा हुआ है तो आप SS नहीं कर पाओगे. आप क्योंकि SS नहीं कर पाओगे तो मैं stage नहीं दे पाऊंगा. तो stage नहीं दे पाऊंगा तो क्या करोगे? Again you have to go here with active management. So active management is going to be an intervention. Active management is what we're talking about, an intervention. It is an intervention, right? This is about intervention. So these are the different stages of the pressure ulcer, and you have to remember all these one, and you have to write it. If you put this in a tabular form, your examiner is going to go gigas on you. बोलेगा यार ये बंदा तो सही में टॉपर है, टॉपर, ठीक है? तो small things, nothing descriptive about it. थोड़ा सा effort लगेगा, लेकिन अगर एक बार effort डाल दोगे तो you know that you are not going to miss out on the score. तो ये बड़ा important description है, right? So do not goof up on this. This is quite important from the exam perspective. So whenever you're writing it, make sure you put it in a tabular form or a tabular state so that it looks quite presentable as well, right? So this is about the stages of the pressure ulcer, right? Now फिर बारी आती है management की. We described it, no? कि now we're talking about active management and the conservative management, right? So what is your conservative management? What is your active management, right? So we're talking about the management of the pressure ulcer. In the management of pressure ulcer, in the management of the pressure ulcer, as we said, we have two components. One is going to be the conservative management, another one is going to be active management. One is going to be the conservative management, another one is going to be the active management. Now in the conservative management, the first advice that I will give is to provide a patient with a water or an air bed. Now when you give a patient with water or an air bed, what is going to happen? The pressure exerted over that area will become less, because rigid beds, patient sits on them or patient sleeps on them, it will have more density and more pressure. No, but if you give a water bed or an air bed, the pressure, that is counter pressure exerted by the bed, will decrease, जिसकी वजह से जी capillary occlusive pressure नहीं gain होगा. ठीक है? अच्छा. The second one is going to be a frequent change in position. There will be a frequent change in position. There's going to be a frequent change in position. Now सवाल ये है कि कितना frequent. Now if a patient is bedridden, for a bedridden patient, it should be every second hourly. And if a patient is wheelchair bound, it is every 10 minutes. The patient should change the position, right? So if it is a bedridden patient, every second hourly. If the patient is wheelchair bound, every 10 minutes there should be change in position. It is going to be change in position. Now the third one, it is going to be skin care. If a patient is bedridden, that is a chronic bedridden patient, you have to make sure that all the diapers are changed clearly, the skin is being dusted well, it is kept dry. You have to use an antifungal powder that you have, so that it does not have that inhalations as well. So you have to make sure all that is taken care of. That is a proper skin care is important. So reducing the pressure by water and air bed, frequent change in position, and skin care are the sets of conservative management. In an active management, because the ulcer is already formed, the first one is going to be the cleaning and debridement. It is the cleaning and debridement. The problem with cleaning and debridement of the ulcer, it creates a big wound, right? So how do you allow that wound to heal properly and at a faster rate? So you have to go ahead with something called as vacuum assisted closure. A vacuum assisted closure is basically a dressing material where you put it and you seal that wound and you connect it to a vacuum pipe, and what happens, it sucks all that secretions and all that component across and then keeps the wound dry and allow the wound to heal at a rapid rate. Currently vacuum assisted closure is a wrong word. We do not use it. So vacuum assisted closure is commonly called as VAC. It is an obsolete term now. We don't use the word vac because you cannot achieve vacuum. You can only create a negative pressure. So it is now called as the negative pressure. It is now called as the negative pressure wound closure system. It is called as the negative pressure wound closure system. If you want to impress your examiners, you can write the pressure that is kept in your vac is going to be minus 125 millimeters of mercury. It is set at an intermittent pressure. It is set at an intermittent pressure, and you need to change the vac dressing every 3 to 5 days. So unlike your traditional dressing जो आपको डेली चेंज करना पड़ेगा, वैक का ड्रेसिंग एक बार लगा 3 से 5 दिन के बाद आपको चेंज करने की जरूरत है, राइट? सो द प्रेशर इज गोइंग टू बी एट minus 125. इंटरमीडिएट प्रेशर आपको रखना है. यू कैन चेंज द वैक इन वंस इन एवरी 3 to 5 days, अनलाइक योर ट्रेडिशनल ड्रेसिंग जो आपको डेली चेंज करना पड़ेगा. नाउ वंस यू आर डन विद दिस, देन यू विल ऐड conservative management protocol. You have to add it conservative management protocol जो अभी आपने डिस्कस किया था. What is this conservative management protocol? Whatever we have discussed it here, this is your point number 3. Now the point number 4, it might require skin grafting if it is superficial, or it might require a flap reconstruction if it is deep. If the pressure wound is superficial but a larger area has been involved, you have to go ahead with skin grafting. But if it is going to be more deeper, skin graft alone will not be able to help it. तो अगर ज़्यादा गहरा wound है, सिर्फ skin लगा हुआ तो नहीं चलेगा. You have to take some amount of fat, sometimes muscle also, and that is what we call it as flap reconstruction. ठीक है? So these are the management of the pressure ulcer. ठीक है? So if it comes down to the exam में ये आपके लिए usually 5 mark का question है. So starting all the way from the pathophysiology of your pressure ulcer to the sites, to the risk factors, stages of pressure ulcer and the management. ठीक है? इसी sequence में आपको लिखना है. If you are able to write the answer in this sequence, your examiner is going to be super impressed, right? So we completed another question which was asked in our exam, and that was your pressure ulcer. Now going to the classification of surgical wounds. ये जो सवाल है बहुत बार आया और बार बार पूछ रहे हैं. ठीक है? So we're talking about the classification of the surgical wounds. चले. So the next question that you have is the classification of the surgical wounds. So talk about the classification. It is the classification of the surgical wounds, right? Again, it's a 5-mark question. So a classification may, rather than trying to remember it as one go, right? Trying to remember it as one go, we'll try to give it as a tabular column so that you don't forget it across. Okay? Now, when you talk about the classification of the surgical wound, I'll create a small table. One is going to be your wound class. We'll define it. The definition of that particular wound class. We'll talk about the example of that particular wound class and the percentage of surgical site infection in that particular wound class. Okay? So this is what you have to determine. So when writing the answer, this is what you're going to consider it. So the wound class on one end, so the wound class on one end, definition on the other, that is description or definition, example and the surgical site infection. Example and the surgical site infection, right? Now, when it comes down to the wound class, the first one is going to be clean wound. We call this as a clean wound. So which surgical wound will be considered as clean wound? So what is the criteria, right? Number one, it should be a non-traumatic wound. It should be a non-traumatic wound. It's a wound that should be created due to an elective surgery. It should not be an emergency surgery, it should be an elective surgery. There should be no entry. There is no entry into natural cavity. There should be no entry into the natural cavity. When I say natural cavity, you're talking about abdomen, you're talking about thorax, you're talking about, the ureters or the urogenital system. No, there's no entry into any natural cavity. It should be a non-traumatic wound. It should be due to an elective surgery, and there should be no entry into a natural cavity. If you satisfy all this, this will be called as class 1 or the clean wounds. Now the examples of the clean wound is going to be thyroidectomy. It is the thyroidectomy, parotidectomy, mastectomy, your lipoma excision, all your hernia repairs, we're talking about the open repairs. Because when you talk about TAP, that is transabdominal preperitoneal repair, you go into the abdominal cavity, there it becomes clean contaminated, right? So these are the examples. The probability of the surgical site infection in these patients are less than 2%. That is why we tell you that a single shot of preoperative antibiotic is enough to cater to these patients. You don't need to extend the antibiotics after the surgery. That's the concept of your clean wounds, right? Now, once you have defined the class 1, that is your clean wound, we'll go to class 2. So this is our class 1 wound. Next, going to our class 2 wounds. So second is going to be, class 2 is going to be clean contaminated. We're talking about a clean contaminated wounds, right? So what is the definition or what is the criteria that fits into a clean contaminated wound? Clean contaminated wound kaun sa hai? Now again, clean contaminated mein, this should also be a non-traumatic. This should also be a non-traumatic wound. This should also be due to an, or it should be created secondary to an elective surgery. It should be an elective surgery. Here you can enter natural cavity. Enter natural cavity under controlled environment. Under the controlled environment. there is no spillage or something like that. No, it will become a clean contaminated wound. Okay? Now, in a clean contaminated wound, what are the examples that you're looking at? Right? Now, the examples that you're looking at are clean contaminated wounds. Examples like hysterectomy. You have uncomplicated appendicectomy. You have an appendicectomy which is uncomplicated. Uncomplicated cholecystectomy. Uncomplicated cholecystectomy. All your elective bowel surgeries. Example like gastrectomy. Elective bowel surgeries, example like gastrectomy. Okay. So all these are considered to be as clean contaminated wounds. So clean contaminated wound का criteria क्या है? It should be non-traumatic. Trauma की वजह से नहीं होना चाहिए. Elective surgery होनी चाहिए. आप natural cavity abdomen thorax में जा सकते हो, but again on a controlled component. देखो examples of your clean wound. No, I'll just add another point here. Your brain and joint surgeries. Your brain and joint surgeries which are non-traumatic also are the criteria for clean wound. Okay? All your brain surgeries, all your joint, for example, knee replacements, hip replacements and all that, all these elective joint surgeries are also going to be considered to be as your clean wounds. Okay? So ये आपका हो गया clean contaminated का, right? From here, we're going to talk about the next class, that is your class 3. So we have other classes of the wound. I'm so sorry, but I have an obsession with line. अगर मेरी लाइन सीधी नहीं है तो मेरा दिमाग टेढ़ा हो जाता है. ठीक है, तो भैया जब लाइन मार रहे हो तो सीधी मारना सीखो. ठीक है, अदरवाइज लाइन मारो ही मत. चलो. So this is about clean contaminated wounds, right? Now the third class of wound that you have is your contaminated wounds. It is going to be your contaminated wounds. ठीक है, so it's going to be contaminated. तो contaminated wounds का criteria क्या? It is acute trauma. So acute traumatic wounds. All your fresh trauma, your acute traumatic wounds. Your emergency bowel surgeries. All your emergency bowel surgery, all your traumatic wounds are considered to be as contaminated. Another one is any wound that requires re-exploration. Any wound that requires re-exploration, that is, you have done an laparotomy, but due to some reason you have to do again. If you have done a sternostomy, due to some reason you're doing it again. So any re-exploration of any surgical wound will be considered to be as contaminated wounds, right? Now, what are the examples which will classify as a contaminated wound? Remember your hollow viscous perforations. Is going to be hollow viscous, like perforation, that is gastric perforation and duodenal perforation. You have the gastric perforation as well as duodenal perforation repair. Your ruptured appendicitis. Your ruptured appendicitis. All your emergency bowel surgery where the bowel is unprepared. So it is your perforations, your ruptured appendicitis, all your trauma debridement. All these will be considered as contaminated wounds. Remember the probability of a surgical site infection. Now in a clean wound, it is usually less than 10%. And in a contaminated wounds, it is approximately 20%. So it is almost double this probability of surgical site infection when you go from your clean contaminated to contaminated. So last criteria that you will see in a surgical wounds. The last criteria that you will see in a surgical wound is going to be dirty wounds, right? It is the class 4, and the class 4 is what we call it as the dirty wounds. Now, dirty wounds are infected wounds. All your infected wounds. Anywhere in the body, if there is presence of abscess, it classifies as dirty wounds. If there is traumatic bowel perforation, if there is a traumatic bowel perforation, so if there is an infected wound, if there is an abscess, if there is a traumatic bowel perforation, all these are considered to be as dirty wounds. Examples, as I've already given you, let's say any abscess example like breast abscess, if there is pelvic abscess, if there is presence of fecal peritonitis, if there is presence of fecal peritonitis, if there is any fistulas per se, it could be a bowel fistula or a perineal fistula, any fistulas, all these are considered to be as dirty wounds. The rate of surgical site infection is here is going to be 30 to 70%. The rate of the surgical site infection here is going to be 30 to 70%, right? So these are the classification of surgical wounds, and this you have to remember it. This table, if you put this table, your answer is sorted. Nobody is going to ask you anything beyond it. This is the table that you have to put for classification of surgical wounds, right? So we have completed another question from our previous exam. That is the classification of surgical wounds. So we're talking about the last topic in the wound, that is going to be your surgical site infection. So take up the next topic, and the next topic is going to be surgical site infection. Now, surgical site infections. Surgical site infections are quite important from the exam perspective also. So by definition, it is the infection. So this is the signs and symptoms. The signs and symptoms of infection. The signs and symptoms of infections after a surgery localized to surgical wound. Because if it is systemic, no, then we'll call it a sepsis. Okay. Signs and symptoms of infection after a surgery localized to a surgical wound is what we call it as surgical site infection. This is what we call it as the surgical site infection. Now, when you talk about the surgical site infections, so there is something quite intriguing that you should know, that is what results in post-op fever. Just give me 1 second, guys. Hold on for a second. Right, guys. Now, as we say, surgical site infection, it is signs and symptoms of infection after a surgery localized to surgical wound, but within how many days, right? So this wound infection is within 30 days of surgery. It is within 30 days of surgery. There's one exception if you're talking about any implants, especially in ortho implants, no, those within 1 year. So if it is going to be post implant surgery or post implant, any infection within 1 year, any infection within 1 year of implant placement, within 1 year of implant placement will be defined as surgical site infection. These are like standard definitions that you have to write it. So the surgical site infection is the signs and symptoms of infection after a surgery localized to a surgical wound. It should be within 30 days of surgery, or there should, if it is an implant, it should be within 1 year of implant placement. That is the first component that you have. Now, all surgical site infections, when you talk about the clinical features, they will present to you, because they're infections, they're going to be associated with inflammation. Every inflammation will have rubor, callar, dollar, tumor. So here you will see what are the signs and symptoms of the surgical site infection. The first one, the patient is going to develop fever, and this is what we call it as a post-operative fever or a post-op fever. Now after fever, there will be presence of erythema, over the wound site. There will be presence of erythema over the wound site. So this is your rubor, right? Now there's fever, there is erythema. Along with that, there could be discharge from the wound site. Now this discharge from the wound site, can be serous. This discharge from the wound site can be serous, or it can also be purulent, that is pus. So initially it starts as serous. If it is left unattended, it is going to become into purulent discharges, right? So patient, say same, rubor dollar tumor. So patient is going to have fever, there will be presence of erythema, there will be presence of discharge from the wound site. All these are going to account for the surgical site infection. They're going to aside for surgical site infection. Now, as we have mentioned, the patient is going to present you with post-op fever. So again, here you have to write it for the causes of post-operative fever, because every post-operative fever will not be because of, it is not going to be because of surgical site infection. So we are going to classify the post-operative fever based upon the day it is going to present to us, right? So when you talk about the post-operative fever, if a patient presents to you with the day one, that is the first day. So day one, if there is a post-operative fever, the most common cause is air. Air is what? Lungs. Lungs is what? It is going to be atelectasis. So it is due to, that's the most common, it is, I'd say, it is due to atelectasis of the lung. It is because of atelectasis of a lung, where the lung is collapsed, right? Especially the lower lobe of both the sides, because the diaphragm remains rested, the lungs cannot expand enough, it gets accumulated, and all the accumulation will result in post-operative fever, right? So the day one, it is because of your lung atelectasis. Now, if the fever is present anywhere between day 2 or day 3, now it is usually because of the cannulas that you have put, and those cannulas start to inflame and cause fever. So that is because of superficial thrombophlebitis. It is going to be superficial thrombophlebitis. It is because of superficial thrombophlebitis. It can also be because of UTI, that is hospital acquired UTI. In fact, if you all remember, the most common nosocomial infection that you can pick up is going to be UTI, that is secondary to E. coli. Okay? Now, so the first one is going to be atelectasis. Day 2, day 3, it is going to be because of thrombophlebitis and UTI. Then you have day 4, day 5. If the fever is seen between day 4 and day 5, it is usually because of surgical site infection. It is because of surgical site infection, or it is because of prolonged immobilization, that is caused DVT. It is due to immobilization. So if a patient starts developing fever on day 4, day 5, always look for the wound site. If the wound site is healthy, always look for limbs, because that is going to be because of deep vein thrombosis, that is DVT. Now, if the patient develops fever on day 6, day 6, especially in the abdomen, it is because of the burst abdomen. Now, burst abdomen is where the abdominal wound has given away. It is called as the wound dehiscence has occurred, and that wound dehiscence is going to result in fever. And whenever there is a burst abdomen, there is a very characteristic fluid that is going to come from the wound site. So there will be presence of salmon colored fluid discharge. There's a salmon colored fluid discharge from the wound site. From the wound site. This is a salmon colored fluid discharge from the wound site, that is going to be on day 6. And anything that is going to be beyond the first week, that is more than or equal to day 7, it is going to be usually some collection associated with the wound site or intracavity. Usually talking about the abdominal surgery, so it is an intra-abdominal collection. It is due to an intra-abdominal collection. It is an intra-abdominal collection, or I can say abscess. Same thing validates for your intrathoracic collection. It is your intrathoracic collection, where again there is abscess that is formed within the thoracic cavity, right? Now this is going to be quite important for us, because when you're going to cater it down, okay, I hope everybody is okay. If you have any questions, you can ask, guys. It's okay, right? So these are the important components of the post-operative fever. So we say the first day it is because of air. The second day it is because of water. Third day it is going to be because of immobilization. So it is stagnant state. Then it is going to be your burst abdomen and the intra-abdominal abscess, right? So the first one is air, then is water. Water is UTI, that is nothing but urine. Then your stagnant state is going to be DVT as well as surgical site infection. Then it is burst abdomen, and the last one is going to be intra-abdominal collections, right? Now, whenever you have a patient with surgical site infections, we would want you to know two important scoring systems which are going to be asked in the exam as well. Number one, I would want you to know something called as the asepsis wound score. We have an asepsis wound score. Another criteria that I would want you to know is going to be a Southampton wound grading system. There is not a Southampton wound grading system. So we have two components that are going to be present. One is going to be your asepsis wound score. Another one is going to be a Southampton wound grading system. Asepsis, the mnemonic itself is going to be asepsis. So what does it stand for? Now in asepsis, A stands for additional treatment. It is the additional treatment required for wound healing. It is the additional treatment required for wound healing. S stands for serous discharge from the wound site. It is the serous discharge from the wound site. E stands for presence of redness, that is presence of erythema. Erythema over the wound surface. Erythema over the wound surface. P stands for purulent discharge. It is going to be the purulent discharge. Another S stands for separation of deep tissue. That is, if infection has gone deeper, it is called a separation of deep tissue. I stands for isolation of organism. It is going to be the isolation of organism that we have sent it for culture. In the culture, it is positive for bacterial growth. In the culture, it is going to be positive for that of the bacterial growth. Right? So you have additional treatment required for wound healing, serous discharge, erythema over the wound surface, purulent discharge, separation of deep tissue, isolation of organism, and if there is stay in hospital. If the stay in hospital is for more than 14 days due to wound infection. Due to wound infection, then it will be positive for asepsis wound score. When we talk about the Southampton wound grading system, again in the Southampton wound grading system, we have the grading system, or we are going to follow as a grade system. So we have on one end we have grade, another one we are going to talk about the description. So talk about the grade of the wound and the wound description. Now, let's say you're talking about grade 0. Now, grade 0 is a normal healing wound. It is going to be a normal healing wound. Then you have grade 1. Here, you will have a normal healing wound. There's no problem with the wound healing, but there will be presence of mild erythema. So, normal healing wound with mild erythema. There is presence of mild erythema. We'll call it as grade 1. Now, grade 2, there will be erythema with other signs of inflammation. So, there will be redness around the wound. So, पूरा wound red होगा. उसके साथ साथ there will be other signs of inflammation. So, when I say other signs of inflammation, I'm talking about there will be pain, there will be fever, there will be some amount of serious discharge also, but not very prominent. Okay? So, a grade 2. Then you have grade 3. Rather than discharge, I'll say the skin is becoming edematous, right? So, in stage 3 or grade 3, there will be clear serous discharge. The clear serous discharge from the wound site. There's a clear serous discharge from the wound site. That is the stage grade 3. Then you talk about grade 4. There will be purulent discharge. There will be presence of purulent discharge. And the last one that you have is grade 5, where you have severe wound infection with or without tissue loss. The severe wound infection. The severe wound infection with or without tissue loss. That is with or without tissue loss. Right? So this is the various components of the scoring system. So there are two important scoring systems which are present. Okay. Right, guys, if you don't like it, it's not a force, ना. अगर आपको नहीं पसंद है, it's okay. Find someone else. कोई problem नहीं. ठीक है. देखो भाई, मुझे जैसे पढ़ाना आता है मैं पढ़ा रहा हूँ. अगर आपको अच्छा लग रहा है तो ठीक है, नहीं अच्छा लग रहा है तो भी ठीक है. ठीक है. So I'm trying to give you concise time में कितना important data in the presentable form मैं दे सकता हूँ मैं दे रहा हूँ. बाकी आपकी मर्जी है. ठीक है. कोई टेंशन नहीं. Now you have the wounds. Two criteria that we have already discussed it. दोनों criteria exam के लिए important है. एक आपका asepsis wound score है, which is going to be absolutely important. Another one is Southampton wound grading system. दोनों surgical site infections के लिए हैं. This is what you have to write when they ask you a question on surgical site infection. ठीक है. Surgical site infection का management protocol same वही है. That is going to be what we have discussed before also. So management of surgical site infection. So management of surgical site infection. Now it's a stepwise approach that you have. Every surgical site infection, step 1, it is to drain the collection. Drain the collection. Step 2, start antibiotics. Start antibiotics, right? Chalo. So drain the guys. You don't need to fight on the chat box. It's okay. ठीक है. We are at a phase right now जहाँ पे all of you are quite matured. ठीक है. हर कोई doctor है तो I hope everybody knows what it likes to be. And especially talking about me, I mean I am quite leveled up, so I don't need anybody's validation. मुझे कोई chat box में नहीं बताएगा कि क्या है क्या नहीं है. जहाँ मैं खड़ा हूँ मुझे पता है मैं कैसे आया हूँ. ठीक है. मुझे पता है मैं कहाँ पे हूँ. मेरे तक पहुंचने के लिए जो क्रिटिसाइज कर रहा है, इट विल टेक अ लाइफ टाइम जर्नी. ठीक है. जिस दिन पहुंच जाओ उस दिन बात कर लेंगे. कोई टेंशन नहीं. ठीक है. चल. सो हाउ डू यू मैनेज अ सर्जिकल साइट इन्फेक्शन? जो भी कलेक्शन है यू हैव टू ड्रेन इट. सेकंड, स्टार्ट द पेशेंट ऑन एंटीबायोटिक्स. गिव एडिक्वेट एनाल्जेसिया. Give adequate analgesia. Give anti-inflammatory drugs. Give an anti-inflammatory drugs. So adequate analgesia, anti-inflammatory drugs, drain the collection, start the patient on antibiotics. This is the first line management. Remember, most of the surgical site infection, after you have drained it, they will create into post-drain wound. So whenever they develop into a post-drain wound, all these post-drainage wound, they must be managed with vacuum-assisted or negative pressure system, right? We have just learned pressure ulcers में हमने पढ़ा था कि vac लगाना पड़ेगा. In the same context, post-drainage wounds का जो management protocol है, उसमें आपको करना है, the patient has to be managed on negative pressure. They have to be managed on negative pressure wound closure system. Okay? So this is what you have to do. So whenever they ask you what is the management for a surgical site infection, these are the principles that you're going to follow for your surgical site management. Okay? So this concludes जितने भी आपकी आज तक के सवाल आए थे wounds और ulcer में से, we have covered all of them. ठीक है, तो आज हमने क्या क्या टॉपिक्स कवर किए वूंड में we have completed everything. Phase of wound healing, factors delaying, ulcer management, types of ulcer, pressure ulcers, classification of surgical wound, as well as surgical site infections. ठीक है, यहां तक ठीक है गाइस? So far so good? कोई सवाल, कोई क्वेश्चन, कोई शक? Can we continue? ठीक है, so this is about all the important questions that is to be on the today's part. ठीक है, so I hope we have covered good amount of topic list. ठीक है, so these are the various components from your wound. ठीक है, because we have a little bit of time left, I will take another session, एक और topic list ले लेते हैं, which we'll discuss. ठीक है, तो ये पूरा आपका wounds का है. Then the question that I usually asked is going to be a small topic that will cover it off, that is going to be burns. ठीक है, तो आपके लिए जो question है burns पे, first is about the Wallace rule पे सवाल है. Management of burns wound. The question was there on the topical agents of burns. Topical agents used in burn wound. Okay. Specifically, they ask you the fluid management in burns. Fluid management in burns. They've asked you burn management per se. Right? So all these were our previous exam question. ठीक है, तो Wallace rule आपसे पहले भी पूछा हुआ है. This was asked for 5 marks question. Management of burn wound was 5 marks. Topical agent and fluid management were 3 marks. And the entire burn management was of 10 mark question. ठीक है, so we'll try to address all of them in the same scenario. So quickly talking about the various components of burns that are present. ठीक है, तो सवाल वही है कि again कैसे मैनेज करोगे, कैसे टिपिकली यूज करोगे, तो how would an examiner look for your answers. ठीक है, so when you talk about the answers in terms of, we start with the burn management. So I'll cover everything in this burn management. The burn is also called as thermal injury. It is also called as the thermal injury. So any patient who has come to you with the burn management or a burn, how would you like to go and address it? So it's again a stepwise approach. So burn management में the step 1, it is going to be your primary assessment. Tomorrow when we talk about trauma, we'll talk about primary assessment in detail. Now primary assessment follows the same protocol as anywhere else. It is going to be same as A, B, C, D, E. So here also, but in burns you will add F, right? So this is what you have to follow in the burn wound management resuscitation protocol. So what does A stands for? Now A is going to be airway with cervical spine stabilization. Airway with cervical spine stabilization. B stands for breathing and ventilation. B stands for breathing and ventilation. C stands for circulation with hemorrhage control. Circulation with hemorrhage control. D stands for disability limitation. It is your disability limitation. E stands for expose and examine. And the F stands for fluid management or the fluid resuscitation. F stands for fluid resuscitation. F stands for fluid resuscitation, right? So burn wound management, step number 1 is the primary assessment. That is going to be in the same context that we've written. It is going to be an ABCDEF protocol, right? Now, once you have done, the step number 2 is the assessment status, right? So step 2 is after the primary assessment. So in step 2, what are you going to do? We have started the patient on primary assessment. So if there is any life-threatening injuries during the primary assessment, you have to address then and there itself, right? Especially in the inhalational injuries, no, there will be airway associated injuries. So you have to secure the airway at the context. Okay? So you've done the primary assessment. Now, once you've done the primary assessment or the primary survey, remember to oxygenate the patient well. So give 100% oxygen. Now, the reason for giving 100% oxygen, everybody knows. In every patient who has underwent burn, if it is a hot water or scald burn, you don't need to worry it. But if there's an inhalational injury or a fire injury, due to inhalational heat, there's some amount of laryngeal or the oral cavity injury also, which will cause congestion or edema, will not allow adequate air to go in, so causing hypoperfusion. In those patients, as a precautionary measure, always start with 100% oxygen, right? Now, as you're doing this, secure 2 large IV cannula. So when I say 2 large IV cannula, preferably it is the 16 gauge cannula. If it is not available, you can go to 18 gauge, but not less than 18 gauge needle. That is your second thing in your assessment protocol. Now, once you've done this, always give injections of tetanus toxoid. That is 0.5 milligrams. It is going to be given intramuscular and it has to be given single dose, that is stat. Right? Every patient, you usually forget to give injection of tetanus toxoid, but then that is going to be an important precautionary measure. So once the primary assessment is done, right? After the primary assessment is done, if nothing is there, you should always look for any warning signs for intubation. Is there any warning signs for intubation? Is there any warning sign for intubation? So when we say warning sign for intubation, what are the warning signs of intubation that you're looking at? Number 1, if there is presence of inspiratory stridor. If there is presence of inspiratory stridor. If there is hoarseness of voice. Post burns, if there is hoarseness of voice, if there is an inspiratory stridor, if there is any evidence of facial burns, if there is any evidence of facial burns, and if there is severe wheezing. If there is severe wheezing. If any one of the following is present, it is better to go and intubate it. These are the warning signs for intubation. Now, if there are no warning signs for intubation, the last thing that you have to do or take up next is going to be the secondary survey. Take the patient for secondary survey. Take the patient for secondary survey. Now, in the secondary survey, I hope everybody understands, this is where you are going to look for the percentage of body surface area burnt. So this is going to be the assessment. This is going to be the assessment for total body surface area burnt. This is going to be an assessment for the total body surface area that is going to be burnt. Now, when you're talking about this assessment, there are two things that you remember in the assessment. The best is going to be a rule. If you're talking about which is the best method, it is going to be the Lund and the Broders chart. It is going to be the Lund and the Broders chart. But if they ask you which is the most commonly used, which is fast, which is easy and understandable, that is your Wallace rule. The Lund and the Broders chart, no, it's an extensive chart. It is difficult to remember the entire chart. So we'll be following something called as the Wallace rule. Now, the Wallace rule is something what we call it as the rule of 9. So we'll be talking about what is your Wallace rule, which was your exam question. Right? So the Wallace rule is what we call it as the rule of 9. Wallace rule is popularly referred to as the rule of 9. Right? So when you talk about the Wallace rule, you should know that you have to picture two components. So the Wallace rule for adult and child is going to be different. I mean, not very different, but slightly different. So we'll talk about the adult component of the Wallace rule. And there is a child component of the Wallace rule. There's an adult component and there is going to be a child component. Sir, I'm reading Robbins but finds its language difficult. Yield is quite less as compared to Indian books. Aniket, यार Robbins is something which is a symphony. ठीक है, जब आप पढ़ना शुरू करोगे तो इनिशियली मजा नहीं आएगा, थोड़ा लैंग्वेज का भी इशू रहेगा. 2 बार पढ़ोगे यू विल गेट जिस्ट ऑफ इट. तीसरी बार पढ़ोगे यू ट्राई टू अंडरस्टैंड. जो भी बाकी बुक्स है ना, दे ऑल समराइज. तो रॉबिन्स में जो बॉक्सेस बने हैं ना, वही बॉक्सेस आपको बाकी टेक्स्ट बुक्स में मिल जाएंगे. राइट? रॉबिन्स इज समथिंग दैट यू हैव टू गिव अ लिटिल बिट ऑफ टाइम. देखो, अगर प्यार करना है तो थोड़ा टाइम देना पड़ेगा. ठीक है? विदाउट इन्वेस्टिंग राइट अमाउंट ऑफ टाइम यू कैन नॉट हैव राइट लव. ठीक है? तो जितना प्यार चाहिए उतना टाइम देना पड़ेगा. रॉबिन्स, हाँ मानता हूँ थोड़ा डिफिकल्ट अभी पढ़ना सेकेंड ईयर में, लेकिन थोड़ा एफर्ट डालोगे इट विल बी नाइस. ठीक है? नाउ कमिंग बैक टू आवर Wallace rule or the rule of 9. ठीक है? So in the adult, let's say this is the head, this happens to be the neck, this is going to be the trunk is going to be the chest as well as abdomen, this is going to be the lower limb, this is going to be the lower limb here, this is going to be the upper limb. Okay, so this is going to be your upper limb. Right? In the child, same thing. This is the head, this is the neck, this happens to be the trunk, this is the upper limb, and this happens to be the lower limb. Now in adult, we will also consider this area. This area is what we call it as the perineum. Right? Now when you look at the Wallace rule, in the adult, the head and the neck together, one that I'm shading in green, the head and neck together, it is going to be 9%. So if I just mark it down, the head and neck together, both, it is a combination of head and neck put together, it will account for 9%. The head and neck will account for 9%. Okay? Then comes the upper limb. That is, the upper limb is going to be from the fingertips to that of the entire shoulder. This is the upper limb. The upper limb is going to account for 9%. The upper limb is going to account for 9%. See, if you look at the palm alone, the palm alone is going to account for 1%, right? That does not mean the entire upper limb is 9 and then you have one more is going to be 10. So this is going to be, palm is going to be 1%. Mohammad Yunus, beta BLS, we will continue. We are not going to stop BLS until we finish the entire Bailey. There is no exception to this. But yes, this week has been a slightly busy, so that is why we did not continue the Bailey and Love series. Next Monday, that is from coming Monday onwards, you will see BLS every evening, Monday, Tuesday, Wednesday, 9 to 10. There is no if and but in that. Okay? Bailey karna hai yaar, Bailey ke bina nahi hoga. Now, when it comes down to the trunk, I divide the trunk into the anterior trunk and the posterior trunk. Right? So let's say this is the anterior trunk, this is the posterior trunk. Anterior is aage, posterior is piche. Trunk is chest and abdomen together. Remember the anterior trunk. The anterior trunk accounts for 18% and your posterior trunk. Your posterior trunk also accounts for 18%. Then it is your perineum which is present here. So this area which I'm shading in red, this is the perineum. The perineum is going to account for 1%. And then you have the lower limb. The lower limb is going to account for 18% each. The lower limb is going to account for 18% each, right? So this is your standard rule of 9, or also called as the Wallace rule. Okay? So in this, you see the entire percentage of the body surface area burned. The head and neck is going to be 9%, the upper limb is going to be 9%, anterior trunk is 18, posterior trunk is 18, the perineum is going to be 1%, the lower limb is going to be your 18%. When it comes down to child, what is the difference that you're going to see? The first difference, when you're calculating the percentage of total body surface burnt in a child, the head and neck here. The head and neck in a child is going to account for 18%. It is going to account for 18%. The trunk remains the same as adult. This is the anterior trunk, this is the posterior trunk. The upper limb also remains same as adult only, that is going to be 9%, right? So when you go with the upper limb, the upper limb is going to be 9%. The anterior trunk, and the posterior trunk. The anterior trunk is going to account for 18%. The posterior trunk is also going to account for 18%. The lower limb is going to be different from that of the adult. The lower limb in a child will be accounted for 14% each. In a child, it is going to be accounted for 14% each. Okay? So this is what we call it as our Wallace rule, or the rule of 9. So in adult, it is going to be all the way in this context. In child, this is there. What is the difference? Remember the head and neck. In adult, 9%. Child, it is going to be, in a child, it is going to be 18%. Limb in the child is 14%. In adult, it is going to be 18%. There is no perineum in child. In adult, the perineum accounts for 1%. Draw this diagram, put the same percentage. Your examiners are going to give you 100% complete marks. Now, once you're done with this, just to get that extra points, no, you can tell your examiner that I also know the definition of something called as significant burn. Now, when do you call a patient is having a significant burn? Now, the patient is known to have a significant burn. Patient is known to have a significant burn if you calculate, if the patient is, let's say, age less than 10 years, age between 10 to 50 years, and age above 50 years, right? So when you talk about the significant burn, I should be knowing that it is age less than 10, age 10 to 50, or age above 50 years. Now, if it is age less than 10 years, if it is more than or equal to 10% of the total body surface area burnt, it is significant. For age between 10 to 50 years, it is more than or equal to 20% of the total body surface area burnt. It is significant. More than 50 years, it is more than or equal to 10% of the total body surface area burnt. If more than or equal to 10% of the total body surface area burnt, this will be called a significant burn, right? Remember, every patient of significant burn must be addressed with fluid resuscitation protocol. It should be assessed with fluid resuscitation protocol. Now, once you have dealt with significant burns, also quickly mention on zones of burn. So zones of burn में क्या लिखना है? Again, there is a small diagrammatic representation to tell that you understand the extent of the injury in a burn wound. So there are three distinctive zones which are going to be present. Now the zone which is going to have a maximum damage, that is going to be right in the center. Then there will be a zone surrounding this damaged area, and there will be a peripheral zone which is going to be at the end, right? The three distinctive zones that are present. The first one is what we call it as the zone of coagulation. Now the zone of coagulation, it is where there is a maximum injury. There will be maximum injury, and this is associated with tissue necrosis. This is associated tissue necrosis, and this is irreversible. This is irreversible. That is your zone of coagulation. Now after the zone of coagulation, the second zone that you see here, this is what we call it as the zone of stasis. This is the zone of stasis. Now this zone of stasis is basically zone with low tissue perfusion. This is a site, this is a zone with low tissue perfusion. Now because there is a lesser tissue perfusion here, this is going to be associated with increased risk for necrosis. There is an increased risk for tissue necrosis. It is not necrosed yet, but again this has got a higher chance of getting into tissue necrosis. Okay? And the last one that you have is the peripheral zone. The peripheral zone is what we call it as the zone of hyperemia. The zone of hyperemia. Somebody saying Nisha, Kaushik, MBBS is tough than NEET. तो इसीलिए ना बेटा NEET is the entry point. No, तभी तो अगर वो क्रैक करोगे तभी ना आगे पहुंचोगे. ठीक है? It's not that tough as such. ऐसा भी नहीं है. हाँ थोड़ा ज़्यादा बोल सकते हो, tough नहीं बोलेंगे. चलो. Zone of hyperemia, it is associated with vasodilation. It is associated with vasodilation. It usually consists of viable tissue. This usually consists of viable tissue, and this is associated, or this zone is associated with least risk for necrosis. This is associated with the least risk for necrosis. Okay? So this is what you are going to write in burns, that is the significant burn, and then you have the secondary component, that is a Wallace rule. Okay? Now it is, how do you do a burn fluid resuscitation? So we will follow the burn fluid resuscitation. So when you talk about the burn fluid resuscitation, now burn fluid resuscitation is calculated according to the depth of the burn as well as the percentage of the body surface area that is burned. Okay? So burn fluid resuscitation may, remember the preferred fluid of choice or the fluid of choice for resuscitation. The fluid of choice for resuscitation. The fluid of choice for resuscitation is going to be your Ringer lactate. It is going to be your Ringer lactate. Now, in order to know that, how would you look at this? There is something called as the depth of the burn wound classification. So based upon the burn depth, This is how we're going to classify. So quickly look at the burn depth. Now, in order to classify the burn depth is classified into first degree burn. You have second degree superficial, second degree deep. There is second degree superficial, there is second degree deep, there is a third degree burn, and there is a fourth degree burn, right? So based upon this, we are going to classify our burn wound. So the first degree burn, the secondary superficial, secondary deep, the third degree burn, and the fourth degree burn, right? So these are the various depth that we are going to analyze right now. So what is the criteria on which you're going to look across, right? So the first one that you're going to look is the structure that is burned. First degree, it is only epidermis. Second degree superficial, it is the papillary dermis that is burnt. Secondary deep, it is your reticular dermis that is involved. Third degree is going to be full thickness of the skin. There is the full thickness of skin, and the fourth degree is the involvement of underlying structure. If the underlying structure is also burnt, it is called as the fourth degree burn. It is called as the fourth degree burn, right? Now, when you look at the color of each of these burns, there will be presence of erythema in first degree. Second degree superficial is going to be bright red. The wound will be bright red in color. Secondary deep is going to be mottled pink, or you can also have waxy white. Either you can have a mottled pink appearance or a waxy white appearance, that is your secondary deep. Third degree is going to be your leathery in appearance, and the fourth degree, it is going to be charred like a charcoal, so like a charred appearance. Okay? That is the color. Next comes the component of pain. Wherever you have skin, there is more pain. First degree will have extreme pain. Second degree will also have a lot of pain. Secondary deep will not have any pain, but there is something called as presence of pin prick sensation. So there will be presence of pin prick sensation alone. Third degree, fourth degree, no skin, no pain at all. There is no pain at all. Then it is blister. First degree will have, may or may not have blister. Secondary superficial will have blister. Secondary deep may or may not have blister. Third degree and fourth degree, no skin, no blister. Right? Now, which of the following is likely to heal? The first degree, secondary superficial, secondary deep will heal. The third and the fourth degree will not heal. It will require your intervention. It will require your intervention. Okay? So this is based upon the burn depth. Now, once you have classified the burn depth, how do you calculate the burn fluid? Right? So burn fluid calculation. Now for burn fluid calculation, we will follow something called as the ATLS formula. That is, the ATLS is Advanced Trauma Life Support. Okay? Now according to the ATLS, how do you calculate the burn fluid? Now according to ATLS, if there is a first degree burn, provide the patient with oral fluids. Provide the patient oral fluids. If it is a second degree or a third degree burn, and if it is a significant burn, second degree or third degree, and it is a significant burn, and if the patient is an adult, how do you calculate? It is going to be 2 ml per kg per percentage of total body surface area burnt. But if it is a child, then it is going to be 3 ml per kg per percentage of total body surface area burnt. If it is a neonate is going to be 3 ml per kg per percentage of total body surface area burnt. Along with that, I will also add the maintenance fluid. I will always add the maintenance fluid to this patient, right? If it is second or third degree burn. If it is a fourth degree burn or an electric burn, it does not matter if it is an adult or a child. In both these patients, I will use 4 ml per kg per percentage of total body surface area burnt, right? So if it is a child or an adult, if it is a fourth or an electric burn, you have to follow your 4 ml per kg per percentage of body surface area burnt. But if it is a second degree or third degree burn, if it is an adult, it is 2 ml, child 3 ml, neonate it has to be 3 ml with maintenance fluid that you have to give, right? Now whatever you have calculated, no, this is what we call it as the burn fluid, and this burn fluid is purely for crystalloids. It is going to be crystalloids, right? Now how would you calculate for colloids if the colloid resuscitation is required? For colloid resuscitation, we follow something called as the Muir and Barclay formula. Now how do you calculate Muir and Barclay formula for the colloids? It is going to be 0.5 into weight in kilograms into percentage of total body surface area burnt. Whatever you get, this is how you are going to calculate the fluid, right? So the burn fluid is calculated. For crystalloids, we are going to use ATLS formula. For colloids, we are going to use Muir and Barclay formula, right? Now here is an important thing. Earlier there was a formula called as Parkland formula that is obsolete. 4 ml per kg per percentage of body surface area burnt. This is how originally the Parkland started, right? So there was another formula which is called as the Parkland formula. The Parkland formula was 4 ml per kg per percentage of total body surface area burnt, but then now Parkland is obsolete. We only follow the ATLS protocol. Now, what is the protocol for fluid administration? Protocol for fluid administration. So, when we talk about the protocol for the fluid administration, remember, first 24 hours, it is going to be crystalloids. If the fluid requirement is there, after 24 hours, you can give colloids, right? So colloids are usually given after the 24 hours or the first 24 hours, right? Now, how do you administer this? I can take a small example to explain you this. Now, example is, let's say I have a 4th degree burn patient who weighs 70 kilograms with 30% of the total body surface area burnt, and the patient is an adult. I can say he's a 30 years old male, right? If you have a question which is like this and they're asking you to calculate the burn fluid for this, now according to whatever we have learned, no, this is 4th degree burn, so it is going to be 4 ml per kg, weight is going to be 70 kilograms into percentage of total body surface area burn, that is 30. So this is going to be 8400 ml of ringer lactate. So this is the 8400 ml of ringer lactate must be given within 24 hours, right? So whatever fluid that you have calculated, this is what we call it as burn fluid. And whatever burn fluid that you have calculated, it should be given, or it must be given within 24 hours. Within 24 hours, right? So how would you give so? So what we have calculated is, for this patient, the fluid requirement that we have gotten. For this patient, the fluid requirement that you have calculated is going to be an 8400 ml of ringer lactate. It is going to be an 8400 ml of ringer lactate. Now, how would you like to administer this fluid? Now, this fluid has to be distributed in 2 equal halves. So 2 equal halves is going to be 4200 ml as the first half and the 4200 ml as the second half. Now, this 4200 ml, which is the first half of the ringer lactate, the first half, and this is the second half. Right, you have calculated the first half as well as the second half of the ringer lactate. Now, whatever fluid that you have calculated, the first half has to be given as fast IV and this has to be given as slow IV. So this has to be given as the fast IV and this has to be given as slow IV. So, but you have to complete the entire fluid resuscitation within the first 24 hours, right? It has to be completed within the first 24 hours, right? Right. So as I was saying, fluid administration, the first half is going to be fast IV, the second half is going to be the slow IV. The fast IV means you have to give within 8 hours. And the second half has to be given within the next 16 hours. So within 24 hours, you're going to administer the entire fluid, and that is what we call it as the burnt fluid administration, right? So there is a protocol for burn fluid administration. So when you come to our previous exam questions, what all did we cover? Did we cover the Wallace rule? Yes, we did. Did we cover the management of the burn wounds? We are going to, we have not covered it yet. We will cover it. Topical agents has to be covered. Fluid management and the burn management we have covered. Okay? So let's talk about the topical agents for the burn wound management. So what are the different topical agents that you have? The topical agents for the burn wound management. Number one is going to be your silver sulfadiazine. Silver sulfadiazine. Then you have the silver nitrate. Then you have the mefenide acetate. Mefenide acetate. Silver sulfadiazine, silver nitrate, mefenide acetate, and then you have the silver sulfadiazine. Silver sulfadiazine with cerium nitrate. Now, whenever you're using any topical agents, the criteria for using the topical agent, you will see whether it is effective against Pseudomonas. Is it effective against the gram-negative bacteria? Can it penetrate an eschar? It's a fibrotic scar that is formed over the burn. And is there any specific side effect, right? So these are the components that are usually looking at whenever you're deciding for any topical agent, right? So we'll see whether a topical agent is effective in these components or not, right? So these are the parameters that you're going to look into these. So we are going to see, sorry. Is it effective in each one of the following or not? Now, when you talk about the silver sulfadiazine, it is extremely effective against Pseudomonas, extremely effective against gram-negative. It cannot penetrate eschar. There are no side effects, right? On the other hand, silver nitrate has a good effect against Pseudomonas, decent effect against gram-negative, cannot penetrate eschar. It is going to result in blackening of skin. It is going to result in blackening of skin, right? Mefenide acetate, on the other hand, has got a very little action against Pseudomonas and gram-negative, but it can penetrate eschar. Problem with mefenide acetate, it causes metabolic acidosis. And once you apply the mefenide acetate, it is going to increase the pain on the burnt area. Now, the best agent that you have is silver sulfadiazine, effective against Pseudomonas, effective against gram-negative, penetrates eschar, and there is no particular side effect. So the best topical agent, the best topical agent is going to be your silver sulfadiazine with your cerium nitrate, right?